types of endometrial or uterine cancer. Type 1 is estrogen dependent and is called endometrioid type uterine cancer. The endometrioid is the cell type lining the uterus. It has 3 grades. Grade 1, which are low grade, meaning less abnormal cancer cells, and grade 3, which has very abnormal cancer cells, and grade 2, which is in between. In case of grade 1 cancer, the chances of grade 1 cancer to spread to lymph glands are minimal, unless the tumor is a large size and deep in the muscle of the uterus. We recommend an MRI of the pelvis to see how deep the tumor is in the muscle of the uterus, which is called the myometrium. The most common approach to treat endometrial cancer is surgery, and minimum surgery required is a total hysterectomy and bilateral salpingo-oophorectomy, which means a removal of the uterus, cervix, and both tubes and ovaries. A hysterectomy means removal of the uterus and cervix total versus removal of the uterus with cervix conservation subtotal. It could be done vaginally or abdominally or laparoscopically, which is a camera surgery. In the case of grade 2 and 3 and other high-risk types, such as uterine papillary cirrhosis or an carcinosarcoma, which is based on an endometrial sampling, the risk of cancer to spread outside the uterus to the cervix, ovaries, and/or pelvic lymph nodes, and sometimes to the omentum, which is a curtain of fat between the stomach and large bowel, is present. A total laparoscopic hysterectomy, or TLH, is when the entire operation, including closure of the vaginal vault, is performed laparoscopically, which is a camera small hole surgery. The uterus, cervix, and ovaries are typically removed through the vaginal vault. A laparoscopic assisted vaginal hysterectomy, or a LAVH, is when ovaries and tubes of the blood supply, and also uterine major blood supply, is controlled laparoscopically. Then remainder of the procedure is performed vaginally. The positioning would have you lying down in the dorsal lithotomy position with the legs in stirrups. Your arms are tucked at the sides and a support is placed around the shoulder to prevent sliding during surgery, as your legs will be high up in the air and head will be down. We will insert an indwelling bladder catheter, and it usually stays for a day. A uterine manipulator is placed in the vagina and has a cannula that is inserted into the cervix at the beginning of the procedure to aid with mobilization and surgical exposure. We use RUMI uterine manipulator. A Verus needle is introduced at the belly button, to which carbon dioxide gas is filled in the abdomen, and then disposable ports are used, through which we use surgical instruments and cautery device such as harmonic, ligature, or bipolar to seal the various blood supply and to cut through the tissues during surgery. A primary 12 mm optical port at your belly button or above it with 2 accessory points in the bilateral lower quadrants, and a fourth 12 mm port is placed above your pubic bone. Sometimes an extra 5th port is needed to assist in surgery. After the uterus is pulled out through the vagina, the opening or the vaginal cuff is then sutured with either an endostitch or other suturing device of the surgeon's choice. The skin incision is closed with a 4-0 monocrel suture in an interrupted fashion. We then inject 10 to 20 cc of 0.25% Marcaine at all incision sites to reduce immediate postoperative pain. Complications of laparoscopic hysterectomy is very similar to those of an abdominal hysterectomy. The laparoscopy conversion to laparotomy 2.5 to 4%, bleeding 2 to 5.0%, urinary tract injury 1.2 to 3%, a vaginal cuff dehiscence 1 to 2%, and bowel injury 0.2 to 0.4%. You can be discharged home on the same day or stay in the hospital overnight and go home the next day. Post-operative instructions include the following. We advise to avoid heavy lifting or straining while the abdominal incisions are healing, and increase other activities as tolerated. Usual recovery period is 2 to 4 weeks before resumption of majority of daily activities. We recommend pelvic rest, avoidance of intercourse or tampons for 4 to 6 weeks after total hysterectomy. Some bleeding and discharge is expected, but heavy bleeding, like periods, is not normal.